It is very, very prevalent, as I'll show you. The whole thing. Really? No one can hear anything?
I don't know. No sound, yeah.
Do we have it now?
No.
Okay. Welcome to Fertility Factor Fiction. Tonight's topic is sexual dysfunction and disorders. Sorry, we had some sound problems there. As a consequence of infertility. We're looking at a recent review from Human Reproduction Update, which does meta-analyses, and we're going to talk about how infertility impacts sexual function in men and women, and as well how to fix it as much as possible. And we'll go over that to share with you. And it has some very, very interesting information that even I wasn't aware of before. So I'll read little bits of that with you, but this is a great article. So make sure that if you have access, you take a look. So it's from a very recent June 1st, 2022 edition of Human Reproduction Update. The article is entitled Sexual Dysfunction and Disorders as a Consequence of Infertility, a Systematic Review and Meta-Analysis. You can probably put that up for screen share. So just tell me when that's up there.
It's up there.
It's up there. Perfect. Okay, so we're going to go through a little bit, talk about their methods. Essentially, they use the PRISMA guidelines, which are common for people doing systematic reviews or meta-analyses. You can read about all that. The topics that they chose included anything related to sexual dysfunction, arousal, desire, orgasm function, and so on. There were lots of different things. So they started with 2,150 that they found through PubMed. They found additional publications, 3,687, and then those were through Embase. And then PsycInfo found another 506. So huge number of studies, essentially close to 6,000 or just over 6,000 studies there. So a very, very large number of reviews that they looked at. At the end of it, the ones that they actually included, like always, get whittled down to very few. Because of the fact that many studies just are not either done in the correct way or don't have strong enough data, or we can't really trust the results. So they ended up at the bottom here, and I can expand it for you so you can see 36 in total for the sexual disorders. And then in the meta-analysis, they included 29. So when they looked at these are all the articles, I'll just skip by that. Oops. So when they looked at the actual outcomes, here is the first one that you need to look at. So erectile dysfunction as measured by the International Index of Erectile Function. In men that were experiencing problems with infertility, if you see where I've highlighted it there, and I'll blow it up for you, the odds ratio for having problems with erectile function was 192% higher. That's what 2.92 means. So very highly significant, a huge increase in men having problems with their erectile function based on this very well recognized international index. So huge increase in problems with erectile function. Similarly, looking at problems with premature ejaculation, they also showed a 110% increase in premature ejaculation for men that were diagnosed with infertility. And ironically or interestingly, this is true even if the male is not the one that has the problem. So if it's a female centered or a female related infertility diagnosis, the male can still have erectile dysfunction problems or ejaculatory problems like premature ejaculation. And these are very robust numbers. You're doubling the incidence compared to normal or almost tripling the incidence compared to normal. So huge increases in the likelihood of these outcomes. When they looked at the erectile function score, you can see that here it was down by 37%. So this is based on the quality of the erection and how long you can maintain the erection, how long it takes to achieve an erection. When they looked at orgasm function, it was not statistically significant in men. So you can see there the minus 0.64, it crosses the confidence interval of 1. And if you look here, you can very clearly see around here that there is a crossing of the line. It just touches the line and rides over it. So that part was not significant. Similarly, or interestingly, I should say, when they looked at the bottom one here for sexual desire was down by over 50% in men who had an infertility diagnosis. So if you're wondering why your partner isn't running right away when you call them because your temperature status is correct and it's showing from your basal body temperature that you need to have sex right then and there, it's because his desire level is probably down 50% compared to normal. So this is a huge thing. Guys need to be recognized for the fact that whether it's their problem or on their partner's side, they may be struggling with this. And this is not something we talk about very frequently. And certainly most guys are very shy to bring this up. So it is something you need to be open about in your discussions. You need to have a clinic that provides counseling and support. There are all sorts of ways to reduce your stress. We have a psychologist, we have a social worker, we have an online program we use for our patients. So all of these things can be really important tools for you to use. And there are other tools as well. Number one is just communication, discussion, going over what is stressful, what is not stressful, and then of course sexually, what interests you, what doesn't interest you, ways to make things more exciting. There's all sorts of studies on that, so that's really important. When they looked at intercourse satisfaction, that's on the next page, that was not statistically significantly different. So that's the first one, minus 0.55, but it crossed 1. You can see the little diamond there is running around, crossing over the 1 line here. And then when they looked at the overall satisfaction, was just on the edge of being 50% less. And so that also was really critical. So all of these things all together clearly indicate that this has a very, very significant impact on men. When they looked at women, they demonstrated that there was a very significant alteration as well. So overall, when they did the female sexual dysfunction score, which is called the Female Sexual Function Index, FSFI, they found a very significant 68% increase in this sexual dysfunction score. So a lot more women saying that they were having sexual dysfunction if they were also infertile. So then they broke it down into individual categories. And I kind of want to go over some of those with you in picture form, and then I'm going to read some of them to you as well. So when they looked at the sexual desire just missed being significant, but was 76% lower for women if they had infertility. And again, the confidence interval does cross 1, but it just barely crossed 1. So obviously, if you had more studies here, we would probably find that it is statistically significant. When they looked at lubrication was also not statistically significantly different. And this one actually didn't differ a lot, but there are individual studies that did show quite a significant decrease in lubrication for women when they had infertility. Sexual arousal, orgasm, and pain and satisfaction were next. So that's on the next page, or the next 2 pages. So not statistically significant for the first. When they looked at the second one, it was statistically significant. So you are going to get less orgasm if you're a woman and you're suffering with infertility. Important to know for the guys who are hopefully trying their hardest to help their ladies out. And then again, overall, their sexual satisfaction scores were statistically significantly reduced, very significantly, 71% decreased. So if you're a woman, just like the men, you're going to have this huge diminishment in your sexual function, your desire, your arousal, your ability to achieve an orgasm. And these are things that are very significant. We have a whole video on YouTube about how women can improve their orgasm using Viagra. And it does actually improve things quite a bit. So that's one of the reasons we often use it in women, is to actually improve their sexual function. So it's one of our most watched videos. Check that out if you get a chance. And so you can take us off the screen share now. So I'll just go through some of the things they talked about, because I think this is really important. So they said that arousal difficulties in infertile women, they did experience decreased arousal and experience fewer physical signs of excitement, including the lack of lubrication. They went on to say a diagnosis of infertility, if you're getting IUI, actually is associated with decreased arousal. So it kind of takes the thrill out of your sex life if you know you have to kind of go through these mechanical procedures to achieve a baby. They mentioned as well, again, that the status of these things is dependent on the partner. So your arousal is dependent on your partner's fertility status. In other words, if you're a female and your partner, your male partner, is unable to achieve orgasm or has a fertility problem and is unable to produce good enough sperm to impregnate you or help you conceive, then you may have diminished arousal toward your partner simply by virtue of the fact that he is not able to help you achieve the desired goal of having a child. When they looked at some of the other elements to this, they looked at talking about the prevalence of these disorders. So when they looked at the prevalence of these things, they said for women, so it went anywhere from 11.3% for any kind of sexual disorder, all the way up to 87.5% in some studies, like overwhelming odds that you will experience some degree of sexual dysfunction. When they looked at the men, it went from 8.9 to 84.9%. So even, very similar results. Very, very strong chance that if you are a couple going through infertility, one of the things we have to recognize as physicians, and the team taking care of you has to recognize, is that you may be struggling with the sexual part of this. Simply telling people to go home and have sex every day or every other day, which I do literally every day when I'm talking to people, ignores the fact that they may not even want to see each other once a month because they're so frustrated by this process. So we have to learn to address this, and you as patients out there need to learn techniques to help improve it for yourselves. They talked about erectile dysfunction, and they also talked about women as well. When they talked about arousal and desire, that was the number one problem. For women, it was followed by other problems that they noted with overall satisfaction, and found impairments in desire for men, and overall satisfaction for men being the number one. In 6 prevalence studies that they looked at, the range of erectile dysfunction was anywhere from 17.6%, which is a lot. It's almost 1 out of every 6. In fact, it is 1 out of every 6, to 94.6%. And they went on to say that for men that at some point in their infertility journey are simply unable to achieve orgasm or ejaculation, it was as high as 90%. So 90% of men at some point will simply not be able to produce a sample because of the stresses that go along with this journey. And then they go on further. They talk about significant delays in conception and sexual function that can cause problems with sexual dysfunction and arousal. This study is kind of endless. Some really interesting things talked about PCOS women. This is PCOS Awareness Month. We have had some posts on that as well. They noted that women that experienced PCOS had even more sexual dysfunction. And if your BMI is higher, whether you're male or female, you're at an even higher risk of having sexual dysfunction. These are really important things we don't often see. I know that there's increased stress with PCOS women. They have more mental health issues. That's well established. We've talked about that many times, but no one's really looked at their sexual function. And this is indicating that you are at a higher risk. There are sexual difficulties that are much more prevalent in this group now. So overall, they went all the way into marital satisfaction. They talked about infertile couples having a very strong influence on their marital satisfaction and their sexual function, because when you're not having sex, it can affect the relationship, and that can very significantly erode the relationship for people. So very, very significant problems. The longer you had the infertility, the more that it was a problem. They did note that whether it was primary infertility or secondary infertility, you could still have sexual dysfunction. It didn't clear you just because you had a baby. And in some studies, it actually showed it was worse. And then, of course, age is a big issue as well. So age can really have a significant impact. How can you help this? Well, number one is communication. So simply talking to your partner about how you're feeling is critical. If you're not communicating in any sexual dysfunction problem, whether or not you're infertile, it's going to be much more difficult for you. So you need to talk about how you feel, how the whole issue has arisen, and what specifically is bothering you. Getting it out in the open can really help to resolve the problem. Number two, you've got to be very attentive to your partner's needs. So if your partner is more about, roses and chocolates, then that's what you've got to do. And if they need, cuddling first, then that's what you need to do. Some people want to start with a massage. Some people want to use lingerie, and it's different depending on whether you're male or female, and each individual is different. So knowing what your partner wants and trying to manage their expectations and their needs is also very, very critical to achieving success. What about tools? Well, believe it or not, there are some tools that help. So whether it's going to an adult store and finding something new that you haven't tried before, implementing toys in your sexual exploits, whether you're doing role play, which can be attractive for some people, or getting into some of the more advanced and aggressive stuff that I probably can't mention on YouTube and Instagram. All of those things can be very beneficial and helpful, and studies show that it can increase your sexual satisfaction rates. On top of that, the other thing to consider is the value of using visual aids. Again, that's probably something I'm not supposed to mention on Instagram or YouTube, but it starts with a P and it ends with an N, so I'm sure you're all well aware of what I'm talking about. So that can help if both of you are accepting of it. And there are versions of that that are actually tailored towards people that have sexual dysfunction, which is very sort of gentle and humane and romantic, rather than a lot of the sort of more aggressive things that are out there, which you don't necessarily get the same benefit from. So there are tools that can help you. There are experts that can help you, sexual dysfunction experts, so sex therapists. They can be useful in certain circumstances. There are books that can be read. A lot of information is out there on what to do. And the most important first step is acknowledging that this is a problem and sharing it with your partner. If you don't do that, it really can become a significant problem, and that can create marital and relationship distress, and that can tear apart relationships. So don't let infertility define you. We always talk about the fact that you're special with or without a baby. That's very, very important to recognize. You have value as an individual and you have value as a couple. So don't lose sight of that. And if your infertility is causing sexual dysfunction, make sure you address that, because we don't want to lose the fact that you do have value as a couple and you are important to one another and to everybody else around you. So I hope that this was useful for you guys to know. Very interesting information in this article. We'll do a deeper dive in a longer video for sure. But that's it for tonight. Let us know what your thoughts are in the comments section for sure. And make sure you hit like and follow or subscribe on whatever social media platform you're following. And we're going to take your questions live. And throw up some likes if you like that program.
Hi, Dr. V&T. Will having the flu during ovulation and luteal phase hurt your chances for a conception when trying naturally?
It would if you had a fever, and overall, if your immune system is particularly highly activated, yes, it would probably hurt your chances somewhat. Anytime you're ill, your immune system is overactive. When your immune system's overactive, your chances of success are diminished with fertility.
DOR, day 10 of stims. I had 5 follicles, one lead 20 M, the rest 7 to 10 M. Should I cancel?
Day
10 of stim.
Day 10 of stim, I would get the 20 and just do a natural cycle IVF. It's a little late for that, but you still could if you triggered today. I definitely wouldn't go any further. Your other ones are going to take way too long to develop in order to be good eggs. You could do duo stim though. So if they did a natural a natural cycle with your 20 and you wait 5 days and start stimming those other ones, they may catch up. So that's a reasonable approach to things, to salvage that cycle and not lose it. And it would salvage some of your drug use.
Can intermittent fasting affect my fertility?
Yeah, so I've looked that up actually. There are not very many studies on intermittent fasting and fertility. What do we know about intermittent fasting? It can help you lose weight, although there are some studies that say that overall reducing your calorie intake versus intermittent fasting actually has the same result. So it may not be that useful, but we do know that it can be somewhat beneficial for insulin levels if it's intermittent, not if it's all the time. There's one very well-known fertility specialist that's telling people to have one meal a day. That's categorically incorrect. And there's loads of studies that demonstrate that. So that particular individual claims that we're not designed to have 3 meals a day. That's completely false. We actually are designed to have 3 to 6 meals per day, and that's what keeps your insulin levels the lowest. There are many studies showing that having 6 meals a day is actually better for your insulin levels than having 3, and having 1 is a disaster. So that's not a good idea at all. But in regards to overall, you want to make sure that you are having the most appropriate diet throughout the week. If you're going to do the intermittent fasting, the other part of it that may be detrimental is it does increase your cortisol levels. And if your cortisol levels are going up, that's not good for fertility. So we're not sure about it yet. If you're desperate to lose weight and you're using it as part of your weight loss, it's probably not unreasonable as long as you keep it intermittent, but I would not be doing that like kind of all the time. It also makes you really hangry, so be careful with that too.
Could being on birth control affect your estrogen levels after coming off it, high levels?
I'm not sure I understand that question. So if you're saying, could you have high estrogen levels after coming off of birth control? I guess it depends on what's causing the high estrogen levels. So if one of the problems is obesity, yes, because the birth control pill will reduce that by increasing your sex hormone binding globulin levels and binding up all the estrogen. But then your body will start reproducing a lot of estrogen and you'll see more free estrogen active. If it's not related to that, it would be, if you have a cyst or something, it could do it. But overall, that's a case-by-case basis. There's no single answer for that. That's a good question. No one's ever asked us anything like that.
Safe anxiety meds during fertility treatments.
Sadly, there are no safe anxiety meds during fertility treatments. So there is nothing that actually will be considered safe. Every medication can have either cardiac, lung, or unfortunately addictive properties for the fetus. So we try to get people off of everything, use cognitive behavioral therapy or dialectical behavioral therapy or any of the behavioral therapies, read books, talk it out, Anything that works for you if you can avoid it. However, your mental health is critical. And for those of you that need to use medications to help support your mental health during this journey, we cannot compromise your mental health in the process of trying to make a baby. So if you can avoid the meds, you should, but don't avoid the meds at the expense of your mental health, because we can't have you harming yourself or harming others. That's not the goal here. So make sure you're doing it carefully and always under the advice of the physician.
I drink 1 black coffee a day. Is that okay for a man? Is that okay to drink?
Yeah, actually for men, 1 to 2 cups of coffee per day improves your sperm function. More than that is detrimental. For women, more than 1 cup of caffeinated beverage per day increases your risk of miscarriage, supposedly. So keep it down to 1 or less. But for men, 1 to 2 per day is recommended.
Dr. V&T. Period.
Okay.
So we're walking into something here.
Uh-oh.
Is it okay to have intercourse after an FET during the 2-week wait? How many days after should you wait, if any? When you transfer 2 embryos, does it often lead to 2 live births, or is this rare?
You should have intercourse anytime you want. I probably wouldn't do it right after an embryo transfer. That's probably suboptimal, just because you just put the embryo in there and you don't necessarily want to rock it around that much. But it's totally fine to have intercourse even the day after, because your embryo is either stuck or it's not. So you're not going to do any damage to it having sex. I usually tell my patients very politely not to swing from the chandelier. So maybe take it easy while you're having sex, but it's totally fine to do so. It's not a problem at all. In regards to what was the second part of the question?
The 2-week wait.
Oh yeah, no.
The embryos.
Yeah, 2 embryos,
births.
right. So 2 embryos, it depends on which center you're at and whether or not they've been PGT tested. So if they have been tested and you're putting in 2 embryos, you have a very high chance of ending up with twins. If they have not been tested, then it's entirely dependent on your age and the quality of the embryos and stuff like that, and the center you're working with. We tried very hard not to put in 2 embryos because it very frequently results in twins. So for us, we avoid it as much as we possibly can.
A question I love.
Okay.
Because you'll see. For IUI.
Yeah.
Okay. I seen your video.
Okay.
About how without trigger shots, chances of conceiving are higher.
Oh, yeah.
Does the same apply for IUI with donor sperm? Thank you.
So actually, we got to take down that video. So we believe that not taking the trigger shot improves success, because there is a study out there that says that. So we actually did it. And for us, it actually reduced the success rate. So we went back to triggering. So we should pull down that video. We got to find that one and take it down. And there's another study from Hamilton that we reviewed that actually said that if you take the trigger shot when you naturally surge, that's better than just naturally surging as well. So it's still a little questionable as to whether it's better natural or with the trigger shot. But overall, whether it's donor sperm or not, we now have gone back to triggering our patients, because we find the results were better when we were triggering versus allowing it to happen naturally.
I think that's the beauty of the show.
We learn as we go. Yeah, we got to take down that video, so we better find that one and get rid of it.
Chances good if you have sex 2 days before ovulation?
Well, that depends on the sperm performance. Excuse me. If you are trying to create a baby, your best chance is on the day of ovulation. So the sperm can live in a woman for anywhere from 3 to 5 days, but that's not every sperm sample. And we test guys here in the clinic where their sperm doesn't even survive an hour once it's ejaculated. Now, it's different inside of a woman than it is in the lab, but we're actually putting it in warm, physiologically appropriate conditions, and some of them don't even survive an hour. So you need to be actually quite careful about that. It is possible to achieve a pregnancy if you're trying 2 days in advance, but you really want to be having sex every day or every other day around ovulation, and definitely on the day of ovulation gives you your highest chance of success. If you're doing it because you're trying to select the sex of your baby, because some people believe that if you have sex like 2 days before or 3 days before, you can determine if it's a boy or a girl. That's actually total nonsense, and it's been proven not to work. So don't try that. Just have sex every day or every other day. The sex of the baby is not determined by what day you have sex on. Absolutely not.
I heard if you're like upside down.
Yeah, and that might do some real damage to someone.
Hey, Dr. VNT, how many days before a transfer is HCG wash recommended?
15 minutes before is the best time. That's what the meta-analysis that we reviewed showed. So we do all of ours 15 minutes before. You want to kind of concentrate it when the embryo goes in. So the best way to do that is 15 minutes before. The half-life of HCG is 5 days. You're only putting in 500 units when you do an HCG wash. So I shouldn't say the half-life is 5 days. It's 18 hours. So in 5 days, it's gone. So if you do the HCG wash 2 days in advance, you've already gone through 2 halves. So you've got just like a tiny, tiny smidgen of HCG still in there. It's not enough. That's the theory anyways.
Yay.
Yay.
You guys, thank you so much for doing a paper review.
Oh, cool.
Dr. VNT are the power team.
Yeah.
Thank you for teaching us.
Oh, yeah. Thank you. We appreciate that. Good topic tonight, too. So,
hey, Dr. V, I used the wrong needle to do my menopure. Am I still good?
Yeah, as long as it's in you, it's fine. But please don't use the wrong needle. That'll be painful. So, yeah.
Happy Tuesday, Dream Team.
Oh, that's nice. The Dream Team. Yeah, that's good. That's sweet. Thank you.
I would love to know the research on which trigger to use. Previously had many eggs but didn't survive the thaw. How do you prevent OHSS without compromising egg quality?
You prevent OHSS by using very little HCG.
Are you going to draw it?
No, I'm going to show our video. Where's our YouTube? There it is.
Hold on.
I know I got to find you again. Home. So we have a video on this, which talks about which one is best. So I'm going to show you that in 1 second. We're just connecting to Tarek's laptop here. There we go. Okay, so the double trigger. Where is the double trigger video? Whoops. It's on the YouTube somewhere. Let me go back to home. Is it? Yeah, right there. So here, it's called single or double trigger. So watch this video. It's going to have an ad. Sorry, guys. So we can skip the ad, but watch this video because this tells you that a double trigger is best. So you want a GnRH agonist trigger with a small amount of HCG, absolute maximum 1500, but it does need to be titrated to your estradiol level. So if you have a really high level, sometimes we just use 250. Sometimes we use 500, 1,000, 1,500 is our maximum, but you definitely want a double trigger. Double trigger has been proven to give you a better live birth rate, so make sure you use that. More mature eggs, more embryos, better live birth rate.
What is your take on older long protocol for egg retrieval of a 36, 37-year-old with good AMH?
No one's using the long protocol anymore, as far as I know, because of the risks of OHSS. So I don't know of anybody that uses it very much. I certainly wouldn't use it in anybody older, because even with a good AMH, you're going to end up with a reduced egg count in theory. There's nothing wrong with using it, but it's not the safest protocol, so very few people are using the long, especially in that category. We're not still screen sharing.
No, you are not.
Okay.
If you have a chemical pregnancy on the 3rd embryo transfer, does this constitute recurrent implantation failure?
Well, it doesn't constitute recurrent implantation failure because you implanted, but there's probably something wrong that needs to be looked at, whether it's your immune system or the embryo quality or sperm DNA fragmentation or whatever the case is. All of those things need to very carefully be evaluated. So that has to be carefully assessed and looked at.
Does Viagra cause melanoma cancer?
Melanoma cancer? Does Viagra cause melanoma cancer? I've never even heard of that in my entire life. I'm happy to look that one up. Let's find out together. PubMed. Oh, actually, you know what? We can do it on this. Let's check it out here. Let's go to PubMed. Okay, I got to share with you, or am I already up?
You're good.
Viagra. Oops. Always learn something new on this show. Melanoma. Wow. Apparently it does. Oh, and then apparently it doesn't. Well, here's a meta-analysis. Let's take a look at that one. Okay, so from 1998 to 2016, they found a couple of studies, including 866,049 men. There's a lot of guys out there using Viagra, of whom 41,874 were diagnosed with melanoma. We found a summary estimate indicating an increased risk of melanoma of 11%, but it was only statistically significant among men with low exposure to Viagra and with low stage melanoma, indicating a lack of dose response and biological gradient. So that means they don't know. That's interesting. I'd never heard of that before. Wow, that's going to scare the hell out of everybody using Viagra. What does this newer one say? No causal link. So a newer study in 2019 said that there is no evidence to suggest that 5-phosphodiesterase inhibitors in patients cause an increased risk of melanoma. A few observational studies that did demonstrate a positive association failed to account for major confounders. So this is what we talked about last week on the show, where we were saying when you're doing your own research, if you don't know how to read the studies, you won't know what the right answer is. So this is something I'd have to look into, but interesting, but it's unknown, I guess, right now. Cool. That threw a curveball.
Curveball of the day.
Curveball of the day. I'm off of Mary.
Yep.
Yeah.
Can B vitamin supplements cause cystic acne? How can I fix it after stopping vitamin B? Currently going through IVF stims.
Vitamin B and acne, I have no knowledge of the relationship between those two. So you have truly stumped me, which is rare. However, the stim can cause acne. So it may be your stims and have nothing to do with your vitamin B.
Not a complete stump, 50% stump. Right? You weren't completely stumped.
It's a partial.
It's a partial stump. It's not a complete stump. You're still good.
Yep.
Okay. Hi, Dr. VNT.
Hello.
Can it sometimes take more than one interlipid infusion to lower NK cells levels sufficiently? And also, are interlipids enough by itself to lower them? Thanks.
It can definitely take more than one try to do that. There's no question whatsoever. Yeah, absolutely it can.
Should my clinic do blood tests while I'm on Lupron Depot? What should my levels be after Lupron Depot?
We don't check our patients' levels when they're on Lupron Depot. Lupron Depot is so strong, it almost always works. So we've never bothered to check anybody's levels of anything while they're on that.
Is it normal to have light bleeding for a week after 11 days of first Lupron shot?
Yes, because Lupron doesn't tend to suppress you until after the first week. And if you took it on cycle day 21, you should still get a period. So yeah, that's very common, not an issue at all.
In my uterus, according to the questionnaire, not me myself, obviously, third day and Prolutex, 25 milligrams daily once do fast on 10 milligrams, 2 morning and 2 evening. Is this enough progesterone for me? Still no pregnant. What should I do? Celaxane 40 milligrams. Clexane 40 milligrams, also used, scratch done.
You should be getting your progesterone levels checked. So there's no amount you take that's enough. You actually have to titrate the dose. So make sure that they check your progesterone levels, and that's how you figure it out. It should be 10 to 30 nanograms per mil, or 40 to 100 nanomoles per liter.
A friend of mine has one tube due to an ectopic pregnancy.
Sure.
Should she go straight to IVF or IUI?
Oh, no, you can still try IUI. It would be ideal if the eggs grow on the side that the tube is on, but you can still try IUI. There's loads of women with just one tube that get pregnant naturally without even doing IUI, so that's fine.
Hi, Dr. V. We had 2 embryos, both split after our FET. We now have 1 embryo left. Is there any way to reduce risk of multiples again?
There's no way to stop a normal embryo from splitting. You can't do that. The only thing that we know is a risk factor for it is assisted hatching. So if they assisted hatch, you could potentially stop them from doing that. Although then you might compromise the chances of it sticking. But no, there's nothing else you can do aside from that.
What is a normal estrogen level for the first trimester of pregnancy?
No one measures estrogen levels in pregnancy, so don't, is the answer to that. It's wildly variable and it depends on many different factors. Nobody is measuring estrogen levels in pregnancy. So if you're trying to, stop immediately, because that's absolutely unnecessary.
Dr. VNT, should we use baby aspirin as prep for an egg retrieval?
Yes.
If we do, how much? Thank you.
Well, baby aspirin is 81 milligrams. So just take 81 milligrams, as long as you don't have a bleeding disorder. And as long as whoever's doing your IVF knows that you're on baby aspirin. It does probably increase your bleeding risk. So use it with caution and talk to your physician as always first. It's probably more important at the FET stage than it is at the egg retrieval stage. So we don't always use it for our patients at retrieval, but we do use it at transfer.
Are vibrators okay to use while TTC?
Yes, vibrators are fine to use while TTC.
Hi, Dr. VNT. After how many transfers would you consider doing NK testing if the person has unexplained infertility and already been tested for autoimmune clotting factors, thyroid dysfunction?
Well, it depends on your center. We would do it after 2. Because usually we're successful within 2 tries. So if we fail 2, we would start looking for a reason. Definitely after 3, we offer it after 2. But you got to see what your center's success rates are.
As a woman, can going to the gym at a moderate level 5 times a week affect my fertility in a negative way?
Yes, if you're really lean, if you're going at it hard in the gym, you can affect your fertility for sure. So moderate exercise is okay. 5 times a week is probably more than moderate. That's a lot, but it depends on what you're doing. If you're going there and you're doing some light Pilates or yoga, that's great. That's fine. But if you're going there and, doing a real hard HIIT training, that's probably detrimental.
Is progesterone of 38.5 4 days after ovulation a good level before 5-day FET?
38.5?
38.5.
Does it say the units? I don't know your units. If it's nanograms per mil, it's too high. And if it's nanomoles per liter, it's just borderline too low. So you have to know your units in order for me to know that. For those of you who are watching, if you are sending us numbers, send us units, because the US and Canada and the UK and Europe are all different. So we need to know what units you're talking about.
What is the maximum dose of gonadotropin safe for stims without damaging egg quality if you have 7 to 8 follicles?
So we are more and more moving towards maximizing our doses between 300 to 375. Occasionally we'll do 450, but I'm trying to steer away from that. There's a very recent study out that demonstrates that high levels of gonadotropins actually damages the eggs. So less is actually better in some cases, and we're trying to keep our doses lower and lower all the time. So yeah, that's what you want to do.
Will the Mediterranean diet change the success rate of an FET, or just try to eat healthy?
No, they've actually got scientific studies, and we reviewed one. God, that was years ago, probably 2 years ago, that shows that the Mediterranean and the Dutch diet both can actually improve your success rate. So we recommend it. That was back when we used to do it over there.
What's Dutch diet, like seafood?
I don't know what the Dutch diet is. Yeah, I have no idea. I don't think it's seafood.
Why do blighted ovums happen with PGT normal embryos?
I don't know the answer to that. So a PGT normal embryo does not mean that the embryo is competent in each and every gene. It just means that chromosomally, the embryo has a balanced set of chromosomes. So 22 autosomal chromosomes and the 2 sex chromosomes. So they're paired, they're matched. But could, the individual genes on those chromosomes be abnormal and lead to a blighted ovum? Yes, that's possible. So nobody knows specifically, but we would anticipate there's still something wrong with the genetics, not necessarily the chromosomes, but the individual gene makeup or the DNA quality in the chromosomes.
A question I'm not sure of.
That you personally aren't sure of?
Personally, I'm not sure.
Excellent. Okay, fire away.
Hysteroscopy or sonohystogram? How do you know which to do for a patient?
Always saline infusion sonohystogram. That's a no-brainer.
Always?
Always.
Never do the other one.
Well, you got to put the patient to sleep for the other one. Why would you do that?
I would not do that personally.
Right. SIS is 5 minutes. It's quick. There's no anesthetic. There's no problems with it. And done properly, it's painless and easy. That's our third biggest video. It's our third biggest video. So yeah, just watch the video. Like, it's completely painless. It doesn't hurt. It's super easy. So yeah, you should always do an SIS first. We have hysteroscopy. In fact, I was doing hysteroscopy today, but it shouldn't be done if you don't need it. It's invasive. It's expensive. Like, if you know you have a polyp or a fibroid from an SIS, then you go and you do a hysteroscopy. Otherwise, no.
Good to know. So never.
Now you know.
Now I know. I'm ready for that next
Never. Time. No, and I also never do a hysterosalpingogram first. It should always be SIS. Once you do the ultrasound, you get all the answers you need, then you can determine. Or if you do your SIS and you can't figure it out, sure, you can go ahead and do hysteroscopy, but otherwise, no.
When is the optimal time to transfer after first baby from IVF?
What is the optimal time to transfer? Oh, I get it. Like, how long after you've had your baby should you do your next transfer? Minimum 6 months, because we want all your babies breastfed for 6 months. If you're breastfeeding, if you're not breastfeeding, please try to breastfeed. If you absolutely can't or don't want to, then 3 months minimum. 6 months minimum for the breastfeeders, preferably a year. But again, that's all because of the baby. Your body's ready within 3 months.
I can answer this question.
Okay.
I won't, because I know you're the man.
No, that's okay.
But I just want you to know.
We got to have a Tarek's corner.
This is a easy one from what I've understood,
all right,
historically speaking on the show.
Okay. All yours.
Is 28,000.
Yeah.
Without medication.
Yeah.
A scam for IVF.
Is $28,000 for one cycle of IVF without medication a scam? I mean, I'm not going to call it a scam. It's probably on the absurdly high side of normal. So just to give you a comparison, and I don't know if you're talking US dollars or Canadian dollars, please, if you're still watching the show, let us know if you're talking US or Canadian dollars. But we do 3 cycles of IVF with the genetic testing included for all of the embryos created from all 3 cycles for about that much. So one cycle of IVF with us is not quite a third, but pretty close to a third of that. So that's a lot. And if it's in US dollars, yeah. Tarek's giving me funny faces over here, but yeah, he did know the answer. That's a lot, right?
My answer was a little bit more colorful of vocabulary choices. But yeah, the same conclusion.
Yeah, I don't want to disparage anybody because maybe their program, includes Rolls Royce picking you up to bring you to your blood test every day or something. I don't know.
That might be worth it.
But yeah, I don't know why anyone would be charging that much for one cycle of IVF. Now,
without meds.
Now, if they're offering you a live baby guarantee, maybe, because our live baby guarantee is still not that much, but it's getting close. But that's where we give you your money back if you don't end up with a baby. So 28 grand for one cycle with no med. Yeah, that's
a lot.
God, I wish you could message us right now on Instagram and tell us, or just, wherever, and tell us if that's US or Canadian. Because if it's US, and for all those of you that are watching, on top of the fact that, quite frankly, in many instances, we do a better job, we're way cheaper than it is in the States. You should come here. We have more and more people coming here from the States. So one of my favorites just arrived today. I hope you're watching.
See, I could have answered that.
You could have answered that. You're right. Yeah.
They didn't even say T on it. It was just for you, too.
I should have let you answer that one.
No. We would have been kicked off of Instagram. Hi, Dr. V&T. Meeting with a reproductive immunologist for the first time this week about RPL. Okay. What questions should I ask? What can I expect?
What questions should you ask? What kind of diagnostic testing are they going to do? What do they think is potentially wrong? And then what's their plan to fix it? If they immediately want to jump to IVF because that's their solution, that's actually not the right solution. So that always turns me off from people that say that. And don't invest a fortune in testing because there is testing available that doesn't have to cost a fortune. So yeah, find out what they want to check, find out why they want to check it, make sure they do a very detailed history on you. Recurrent pregnancy loss can be related to the guy. If he's smoking, drinking, using drugs, that's probably the source of the problem because there's high sperm DNA fragmentation. Sometimes you can solve this just by getting people to quit. So it doesn't require IVF, no expensive tests, no fancy immunological treatments, just like get off the cigarettes or the marijuana or the alcohol. So you got to make sure they're asking you the right questions, which is kind of difficult if you are a patient, but you want to make sure they're asking you a lot of detailed questions about your entire history and your partner's history. Find out what kind of testing they want to do, find out what the costs are. And if they're pushing an agenda before they even know what's wrong, those are the people that just kind of want to make money. I'm not really a fan of that. So I always want to know what's wrong before I tell my patients what they should do.
Yeah. Dr. V&T?
You look very confused right now.
I scrolled down to see if they answered.
Oh.
So then when I went up, obviously.
The 28,000 one?
Yeah. I'm trying to find the update.
I'm so keen to find that out. Yeah.
I was looking for it. Thank you for the informational videos. We all appreciate so much. What FET protocol would you recommend for someone who is 42 years old, 8 euploid embryos produced from a recent egg retrieval?
That's insane. 42 and you made 8 euploid embryos? That's incredible. Congratulations. Letrozole. So letrozole protocol is proven to be best. I think it's the newest edition of either human reproduction or fertility and sterility. There's a long article that says we should basically abandon all the other techniques except for natural and letrozole. Lots of supplements. We use antibiotics and lots of probiotics. Make sure you're on the right amount of vitamins. Use melatonin. Make sure your weight's appropriate. And then we use progesterone in oil and vaginal progesterone both. And then get your levels checked and do your transfer.
Hi, Dr. V&T. Can you please remind me of the letrozole dosing for lining prep instead of estrogen? Can you also mention how often progesterone should be checked after FET?
5 milligrams for letrozole, days 3 to 7. Your progesterone should be checked after 3 days, and then we check it again on the day of the transfer or the day after, and we don't check it again after that.
Hi, T. And Dr. V. I did. I think I deserved a little bit of it. That was the first one today. Like
There you go.
It's getting difficult.
Yeah.
I'm losing self-esteem by the minute.
I bought lots of chocolate so he could wallow.
I'll boost
in the
myself
misery
up.
after.
That's
Yeah.
right.
Yeah.
Our FET transfer was unsuccessful. We are moving over to your clinic and going to go with donor eggs.
Oh, okay.
How long is the process to have the donor eggs transferred?
Well, it depends on how picky you are. So from start to finish, there's some testing we need to do for you, especially for your partner. We also need to test you, and then you got to find a donor, which takes a couple of months. She needs to be available. Then we got to make embryos, and then we can do a transfer. So minimum, like 2 months. Maximum probably 4 to 6 if it took you a long time to be picking the right donor, and that's dependent on you. I mean, we've got people that are asking for supermodels with a PhD. That's going to take 6 months. And we've got people saying, I want a reasonably intelligent, brunette or blonde, and eye color doesn't matter. I mean, that's not so picky. So it's a lot easier to find people that fit that criteria than a supermodel with a PhD, because they're definitely more rare. So that's, all dependent on you and what you're choosing.
So that's requested, these sort of things.
We actually had a guy that asked for a model with a PhD. It took me 6 months or so, and connecting him with the right people till they found him what he wanted.
Interesting.
Yeah.
I didn't know that existed. I didn't know you could pick like that.
They actually found him a model with a PhD.
Wow.
Yeah.
That's interesting.
Yeah.
Hi, Dr. VNT. Can you please discuss the frequency?
Your face.
I don't understand, but you'll probably understand.
Okay.
Yeah, you can read it. I'm reading it wrong. I don't understand.
There.
Right here.
Can you please? Oh yeah, I can't. Yeah. Okay. So for those of you that need lit therapy, there is an alternative, possibly, but it has not been proven. There are studies in the literature that talk about the decreased risk of preeclampsia because of immune sensitization between a man and a woman if certain bodily fluids from the male are consumed by the female. I hope I'm being very professional about this. This is the PG version of this, guys. So if the ejaculate is consumed by a woman, it can reduce the risk of preeclampsia potentially. It wasn't a well-done study, but it's there. So for people that are in need of lit therapy and can't afford lit therapy, this may, and I emphasize may, be an acceptable alternative. It has not been studied. It is merely a suggestion, and I have no idea what the appropriate frequency is, nor what it takes to convince one's spouse to engage in such activities. So it is merely a suggestion. There is a study, though, that shows that doing that reduces the risk of preeclampsia and several other things, too. So it might work. Yeah, that one I was really treading the line.
I gave up. I said, I don't know.
Your face was like,
it's a lot.
Like, yeah.
For me, I couldn't.
Okay, keep the show PG, people. Yes.
Well, it's from the, we walked into it.
Yeah.
Right. When can you take a warm tub bath after an FET?
A warm tub bath? Probably a couple days later. Yeah. I'm going to be laughing about that one next week. Oh, that was good. Priceless. Thank you for asking that. I wonder if that was a guy or a girl asking. Keep going.
It's hard.
Okay, go ahead.
Okay.
Yeah, I'm going to try and keep the face.
Yep.
Straight face.
So, in my uterus, third day, and Prolutux 25 milligrams daily.
Isn't that the one we did?
No.
Oh, okay.
This seems different.
Okay.
Yeah. Prolutux 25 milligrams daily once. To fast on 10 milligrams, 2 morning and 2 evening. Is this enough progesterone
Yeah,
for
that was
me?
the one. Same one.
Oh yes, Claxane. That's right.
Yeah. Can't answer that. You got to get your levels checked.
Okay. What is the normal estrogen level for the first trimester of pregnancy?
No, you asked that one too.
Scrolled up too much. Sorry.
It got thrown off.
I got really thrown off. Thank you for a review on using a few days of gonadotropins for IUI. Is PCOS in PCOS patients?
Yeah.
Can you increase live birth rates and decrease multiple risk in individuals without PCOS? Chances at 37.
We don't know. That study hasn't been done, but I would theoretically think it does the same. So I would certainly think it's reasonable to try.
When doing an FET protocol, how long is it typically before the actual transfer day?
Oh, well, typically I'd say somewhere around 19 days, typically. Maybe on the earliest 17 and on the longest like 23, 24. But that's generally around 18, 19 days.
An endo for all time, no pregnant. Should you recommend me immune protocol or some other tests?
What? Let me see that one. I have no idea. Where is that?
Here.
In endo for all time, no pregnant. I have no idea what that question means. I'm sorry. If you have endometriosis, is an immune protocol useful? There's no specific data on that, but I'm going to look it up because lots of people have been asking. It does make sense to use an immune protocol because your immune system is overactive when you have endo. And there are studies out there. I've never specifically reviewed that though, because we use an endo protocol, which reduces the inflammation. So I don't think you need an immune protocol on top of it.
Hi, Dr. VT. My clinic suggested donor sperm due to a fertilization issue.
Okay.
We aren't ready to consider that yet. Any suggestions on how to improve fertilization?
ICSI. Let me start with the basics. So first you want to improve the sperm. So ejaculate every day or every other day. Keep the testicles cold. No smoking, no drinking, no drug use. And when I say no, I mean zero, so none. And then make sure that you're not wearing anything tight around the testicles. And if your weight is an issue, bring down your weight. So all of those things can affect a man. And get the testicles checked with ultrasound to make sure there's no varicocele, those sorts of things. So all of those can improve sperm quality. Take loads and loads of fertility-specific vitamins for men that can also help as well. With regards to the fertilization itself, go to a center that has sky-high ICSI rates. So, our success rate with ICSI is like over 90%, usually 95%, and often 100%. Some places are only getting 75%. So go somewhere better. That's critical for you as well. And then lastly, there are things you can use to increase the chances of fertilization, like oocyte activation, ionophore activation, and blastocyst development. So those sorts of things can be important. But if your problem is just fertilization, I'd say first find a lab that does really great ICSI. And secondly, do everything you can to improve the sperm.
Taking 2 doses of Viagra kills the fertility forever in a man? Question.
Taking 2 doses of Viagra kills fertility? No, Viagra has no negative impact on fertility whatsoever.
Are there any natural supplements I can take to help improve egg quality? Already taking CoQ10.
We don't know, and it depends on your diagnosis. Vitamin D we know helps. We know CoQ10 might help. DHEA, which is kind of a natural supplement. And then your prenatal vitamins, iron arguably as well, and B12 if you're low in B12. Those and the fish oils as well. All of those have some evidence. None of the other ones have strong evidence to support their use. But if you have PCOS or endo, there are some additional ones that have evidence that help. Inositol, NAC, resveratrol being 3, and curcumin for the endo patients. We're at 904.
I can give you this one.
Okay, give me one more.
I've had endometriosis since the 8th grade.
Oh.
I've had laparoscopy before each of my children and had to do Clomid. I have 4 children. I'm 41 years. Only can endometriosis affect my pancreas area? And should I have another laparoscopy? My last child is 7 years old.
I'm not sure if you're asking if you're trying to get pregnant. If endo is around your pancreas, you need either a gynecologic oncologist or you need a laparoscopic general surgeon to operate on you, because that's like tiger territory. The aorta is near there. The inferior vena cava is near there. No one with average skills should be operating up there. That's a very dangerous area to operate in. So that's something that needs to be looked at by a team of doctors. In regards to pregnancy, would I go chasing endo around your pancreas at 41 with 4 kids to achieve another pregnancy? I would probably try to talk you out of that because it's got some very significant risks associated with it. But if you really, really, really wanted to, I'd probably try suppression for a couple of months first and then your Clomid to see if it worked. And if that didn't work, then you can go down that very risky territory of going in there to deal with pancreatic endo. Are there like a million questions?
Yeah.
All right, guys, we got to wrap it up for the evening. Thank you very much for watching Fertility Fact or Fiction. Make sure you give us lots of comments, likes, and subscribe and follow on any of the social media channels that we are on. And we will see you again next week, I think, for Fertility Fact or Fiction. Have a great night, everybody. And thank you for those very interesting questions. But keep it PG. I can't get in trouble on social media. Have a good night, guys. We'll see you later.